I want to talk briefly about concept maps. In general, you've all done a really good job. But I'm grabbing this one because it's a really great map. I like it. And in particular, I want to... No, don't look at who it is. No, you're not supposed to know who did this. I'm sorry. I know. I think it's okay since I'm not pointing this one. This is an exemplary example. So let's talk about this briefly. So there's a lot of good information in here. And what I like is the connections between things, how the meds connect to the condition, to, what's going on. But in particular, and this is where people got confused, was about nursing priorities. And at least what my interpretation for this class of what the nursing priorities are. My point of view about nursing priorities, and you may have other instructors who have other things to say about it. So that this is not gospel truth. This is just Bob's point of view. When you walk into that room, is your patient the same, better, or worse than the last time you were in that room? Based on what you know about your patient from your report, the information in the labs, history and physical, what they're being treated for, you should be able to come to some conclusion about what are the primary things you need to be looking for with that patient that could go wrong. Going right is really nice too, but going wrong is what to me is, are they going downhill for some reason? And priorities, the word priority means what's most important followed by what's next important. So, if you put the least important thing first, to me, we're not on the same path here. So when I start thinking about priorities, I'm looking for things around their ability to breathe. How is their heart working? How is their brain working? So this is a patient who's got severe problems with electrolytes. She's got renal failure, fluid overload. So the things that are in my head as a nurse was, are they breathing okay? What hints do I get about their breathing? Well, the last time I had a conversation with that patient, they made sense. Are they still making sense? Are they having any complaints? Are they exhibiting any anxiety? Are their O2 sats good? These are all things I can do in the room, in the moment, in seconds. I don't have to go send off for an ABG. I don't have to send them, I don't have to get an X-ray. I can walk into that room and say, they look good. They're still talking clearly, they're still making sense, they're not exhibiting any signs and symptoms, their blood pressure's good, I look at the heart monitor, it's looking good, I'm good. That's what I'm thinking. When I'm talking about nursing priorities in terms of concept maps, I'm really thinking about the real basics here. Think of the ABCs, airways, breathing, circulation. When you walk into the room, are they doing better, worse, or the same? And that's really what my focus is here. The nursing diagnoses are really good. They help direct, they kind of talk to each other. Your nursing diagnoses probably should be relevant to what your priorities are. So with the electrolyte imbalance, what are your concerns? Just arrhythmias, right? And because of fluid overload, maybe they might have difficulty breathing because their lungs are filling up with fluid. So that's where I'm at. Does that help clarify? I know I responded to several of you yesterday about sort of looking at your priorities again, where I'm at. And some of you are doing really great, really detailed stuff, but you're not seeing the forest for the trees. And this is a case of you got to step back and say, how are they doing? And that's all really I want to... Are there questions about maps? Did SpiderScribe work for most of you? A couple of you chose to do Word. That's fine with me. I used to do all my stuff in Word because SpiderScribe didn't exist. But frankly, SpiderScribe's a lot less work to do this with. Well, actually, you can copy and paste. Are you on a Mac or a PC? I don't know. Yeah. Yeah, on a PC you'd highlight it and do a Control-C for copying, Control-V for Unfortunately, I don't work with Macs, so I'm a useless resource in that regard. I apologize. But if somebody finds out how to do a copy, there is a little hint somewhere on the top of this thing about doing stuff with a Mac. Somewhere up there it says, I'll go back and look, but I remember seeing something in the title bar about using it with a Mac. Maybe there's a hint there. But yeah, in terms of like just drawing up a map and hooking arrows and stuff together, I do agree. I think it's pretty awesome. I wish it had a double-headed arrow. That's the only thing that I feel like it really could use, because there's things that, you know, they interconnect, they go back and forth. Any other questions about concept maps? I mean, basically, what you're going to get in the future will be another case study that you have to read and evaluate, figure out what the vitals are. I would really prefer that you include both their abnormal and normal data, but if you just include the abnormals, I can live with that, you know, the things that are out of whack. But it helps me to know that you really are clear on the concept if you include both. And this one is actually perhaps even a little more detailed than you need. This is a really nice map. Okay? Yeah. I mean, the one that I haven't given you a case study for yet? The one I haven't put a case study up for yet?
So there's one due on the 25th and one due on the 1st, like back to back. So are we assuming that you're pushing the 25th back to the 1st, and then pushing the 1st back to...
Let me go back and review my assumptions, because I had to, you know, we have fallen behind in some of this stuff because of the way the class has fallen out. And if I need to adjust, I will.
Okay, perfect. So you'll just let us know what the next one's due.
Yeah, real soon now. I promise. I really will. You know, it's not my intent to make life totally miserable, just semi. What? Okay. All right. So let's talk about heart problems. Okay. We are replacing so with okay today. No, because I'm trying to lose a bad habit. So let's see what if we can actually get this YouTube to play, just out of curiosity. Oh, I forgot to hook up the sound, so I guess we're not going to do that. Never mind. A lot of people have had heart issues. Bill being one of them. You know, I mean, he was known for his, you know, his proclivity for Big Macs and other kinds of good stuff. Oh, I really, you know, I made a major mistake here without having. I don't have my notes. I would like. That would. Okay, you get an extra 5 extra. You get 5 more points on extra credit. That's okay. It's only printed on one side. I can deal with this. Okay. This way, at least, I will make some sense while I'm talking to you all. Okay, I'll put my glasses back on and see what I can do. So as this slide starts out with, we have a lot of well-known people who have suffered from, you know, heart attacks and are at great risk for heart attacks. Coronary, you know, artery disease, heart attacks are really still the primary killer of people in the U.S. The rates are on the decline overall, and that's because we're much more aware of things. You know, Kaiser has had their whole heart program, and they actually have evidence to support that their approach to holistic care, if you want, that we're going to take a look at your diet, your lifestyle, and everything. They actually have demonstrable results with a 20% reduction in the rate of heart disease for their patients. So it says something for the HMO model that it really can work if you are seeing the same doctor and the same providers all the time. You are, as a group, probably much more aware of your cholesterol levels and your exercise levels and everything else than I was when I was your age. We just sort of assumed that, you know, it was normal. You had steak and potatoes and it was good, and you didn't worry about things like that. And then, then actually when I was in my 30s, cholesterol became, you know, the great evil. And of course now it's back to being just, it's another dietary. Do you know why cholesterol went from being dangerous to we don't really care so much again about dietary cholesterol? Well, the whole emphasis was on dietary cholesterol. Don't eat eggs, don't eat meat, don't eat blah, 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 blah. Why has that fallen out of favor? So yeah, we've got all these new medications for cholesterol management, but actually that's not the reason. Well, it has to do with how we actually metabolize food. Turns out that dietary cholesterol has almost no impact on your blood levels. Where does cholesterol in our blood come from? Oh, come on, it's in your book. It's in lots of books. What makes cholesterol? One organ. Not the pancreas. Yes, the liver. So it actually doesn't matter so much what you eat. What matters is what is driving your liver to make either the high density or low density lipids. And that's actually where the cholesterol management drugs come in, is they impact the liver. Should you take, if you're on, atorvastatin, one of the statins, should you take that at night or in the morning? Should your patient take it at night or in the morning? When does the liver actually make most of the cholesterol? It's on its own little circadian rhythm. Probably when you're sleeping. So the recommendation is you should take your statins in the evening, so that the highest levels of statins in your blood are there during when your liver is making making cholesterol. So let's talk about the normal anatomy and physiology of the heart here. And having just done this quiz, you can now name all of these, can't you? Does that image look familiar? No, not really. No, it's not it's from a different book. But my God, it is a heart. Human heart even. So what's the only artery that carries deoxygenated blood? I see you smiling. Want to go with it? Okay. Yeah. Yeah. The pulmonary artery has the blood that hasn't gotten to the lungs yet. Yes, it's the only blue artery. What's the only red vein? Well, what runs into the heart from the lungs? Pulmonary vein. So, by definition, veins go to the heart, arteries go away from the heart. And there's only two that carry, there's the pulmonary artery is the only one that carries blood that is deficient in oxygen. And the pulmonary vein is the only one that carries, it's the only vein that carries oxygen-rich blood. Everybody else is doing what you normally expect. Yeah. So, well, if you stop and think about it, you look at these. Unfortunately, these images, they show really sort of the major diversions of the arteries. They don't show the arterioles, but yeah, they are limited to where they can get. So if it's an area that's too small for a stent to reach, that will cause a problem. That becomes then a candidate for a bypass graft. But yeah, it's often where the arteries split up and stuff, there's, turbulence there. Are stents placed in arteries or veins? Yeah. Hopefully the concern is about getting blood that is oxygen rich and bearing nutrients to the heart. How it gets away from the heart is less of a problem. Although you can put stents in veins, if they've got like peripheral vascular disease and stuff like that. But that's not common. So the blood goes through the vena cava into the right atrium, into the right ventricle, into the pulmonary artery, into the lungs, out of the lungs, then into the pulmonary vein, into the left atrium, left ventricle, and then out the aorta, right? When does the heart actually get blood? When the heart beats, when does the heart actually get blood for itself? When does the blood get to the heart muscle that the heart needs to keep going? So you have systole and diastole. When does the heart get blood? So during systole, it's compressed, it's squeezing. So during relaxation, during diastole is when the blood, so actually what happens is, you squeeze it out and it goes up to the coronary artery, which comes right off of the aorta, and during relaxation, that impulse shoves blood into the heart muscle that is now relaxed. So if you have high blood pressure and your diastolic blood pressure is 100, is that going to allow the heart to get as much blood as somebody whose diastolic pressure is 50? It's like a high pressure system, and everything's pressurized. It's harder for the blood to get there. That's why one of the reasons of elevated blood pressure actually can reduce blood flow to the heart. Okay. So you now all know where the LAD is, right? What's the LAD? Left anterior. Does it go up or down? Descending. Okay. What about the one that goes around the heart? What's that called? Circumflex. Circum, like a circle. And flex. Well, flexible, I don't know. So the right coronary artery, where does the right coronary artery go? You're making this too hard. Where does the right coronary artery go? To the right side of the heart. Okay. You guys are making it too hard. No. Oh, we might answer wrong. No. So which side of the heart is more important to your survival? Yeah, because that's what pumps the blood to the rest of the body. So people that are in right-sided failure are going to be less impacted than somebody that has a left-sided failure. That's not really part of the lecture, but I just thought I'd throw that in there. Oops. Coronary arteries. Oh, we've just talked about this. You have the circumflex, the left, the aorta. Where does the aorta go? Is there an abdominal aorta? Is there a thoracic aorta? Where do people get aneurysms? What's a triple A? All of the above? No. Perfect. Yes. And nurses and doctors will talk in code. He went in for a AAA repair. So if you don't know the code, you don't know the conversation. Okay. What is the problem with this? We'll do that. So who's in the worst danger here? Which patient? Somebody with a blockage in the circumflex The RCA or the LAD? Have any, some of you, I know that in my clinical group we've had some people that are on the telemetry unit, the step down. Have you seen in their notes about like the level of occlusion, what percentage of occlusion and which vessel was occluded in the doctor's notes? They went in and they did a stent because they had. Nobody's seen anything like that? Do you remember what it said? Maybe the RCA or whatever. A lot of times people get multiple stents. I still remember talking about a patient who had the full metal jacket. She had 8 stents placed. It was, one of those nursing and doctor jokes, full metal jacket. But so what you'll see is the percentage of occlusion determines in part what kind of treatment they need and how critical they are. If you have a patient who has a 90% occlusion of the LAD, are you concerned about them before they go in for their procedure? Why are you concerned? It means they have 1/10 of the available vessel available to get blood through. Is that going to be easier to block off with a clot? So those are the people that experience sudden coronary death, cardiac death. They get a small clot, but since they have such a small opening, boom, it just plugs it up. They may be symptomatic. They may have angina. You get them on a stress test and you'll say, oh my God, look at the whole. So if the LAD supplies blood to which side of the heart? Mostly the left. So the harder you work, the more blood it wants. And so if the LAD is 90% occluded, they're not going to be able to exercise very effectively, right? They're going to be severely impacted. Then we'll talk about angina in a minute. Okay. So what is the EF? What's the ejection fraction? Okay, how much is pumped out as a fraction? So what are they going to talk about? If you're reading what is a normal ejection fraction? 100%? So every time the left ventricle pumps, does it kick all the blood out? So maybe it's not 100%. 75 to 80% is normal. So if you're reading your patient's history and they say they have an EF, ejection fraction, of 20%, what does that tell you about that patient? That they're having... Well, it's just not leaving the heart. So it says the heart's really not effectively beating. This is somebody that's maybe in left-sided failure. So their heart is so damaged that when the ventricle contracts, instead of getting 80% of the blood out, only 20% leaves. So what does that mean to the rest of the body? Is it getting blood? So what does that mean for their ability to walk across the room? Walk up a flight of stairs? Can they do that? Are they going to be short of breath after like 3 steps? Have you taken care of a patient yet who gets up out of bed and can make it 3 steps and that's it? Not yet? You will. Somebody with like a 15-20% EF is, sometimes they're referred to as cardiac cripples. They really can't do much of anything because they have no reserve.
So what about, like, I had a girlfriend a while back who had clots in her lung.
Okay, so what are clots in the lungs? Those are called pulmonary. What's the word for a clot? Or what's a blockage in the lungs? We covered this a couple of weeks ago in lung problems. Embolism. Yes. Okay. So she had pulmonary emboli. Okay. Okay. So is that because of her heart or because of her gas exchange? So she had a VQ mismatch. So She was moving blood through, but where the blood was going wasn't where the oxygen, and so the exchange was impaired.
So how can you tell the difference between the two?
EKG, stress test, the VQ scan.
When somebody comes in,
Well, their symptoms are going to be a little different because getting back to that first picture of the heart, when does the heart get blood? During diastole, right? So if your heart is only pumping out 20% of the blood, how much blood is getting to the heart to even replenish the heart? Not very much. So what are the symptoms of the heart starving for nutrients and oxygen? And angina, and which would be, what would their symptoms be? Chest pain, tightness, maybe reading down. So the symptoms of heart problems. Whereas the symptoms for pulmonary embolus are going to be maybe more diffuse. There might be lung pain, but they might have, right or left sided. Okay, so she had a sense of malaise, excuse me. She just didn't feel very good, had lack of energy, but her heart wasn't struggling, so she wasn't seeing the symptoms of a muscle that isn't getting enough blood. You all know what the burn is, right? You've all exercised at some point enough to start developing a burn. That's just, that's lactic acid buildup. That's muscle that's not getting enough oxygen. And that's really what's going on with the heart. Same thing. During a heart attack or angina, is the heart's not getting enough, and it's doing the same thing any other muscle does. I don't like that. It's starting to create, the anaerobic byproducts, which it doesn't. The heart muscle is different than your voluntary muscle in one specific regard. You know what that is? Well,
what do you mean it's different from other muscles?
does voluntary muscle actually have stored reserves that it can draw upon in terms of, glucose, if you want, glycogen? Can the muscle convert directly to the sugar that it needs to run in your voluntary muscles? Yeah, there's actually, your voluntary muscles actually have a little reserve in that regard. The heart doesn't. No. No, it's not about muscle memory. It's just about that the muscle, voluntary and involuntary muscle, are different. And one of the things about myocardial muscle is it doesn't have any reserve, really. It's running all the time, and there's no space set aside to hold on to extra sugars and stuff so that it can go for a while anaerobically. It really suffers very, very, very quickly. What's cardiac output? Well, stroke volume plays a role in cardiac output. I see a hand up back there. So what's the measure of cardiac output? Would it be like liters per minute? Yeah. So it's heart rate, which is in beats per second, times the stroke volume, which is in mLs, and so it says, your cardiac output is, X. Stroke volume, of course, stroke volume is the volume of actual blood leaving the heart. So the stroke volume is related to your ejection fraction. How? How could you use the stroke volume to get to your ejection fraction? You won't have to do this, that's the doctor's job, but you should know how they get there.
What's the equation?
Yeah.
You're trying to figure out what the ejection fraction is by factoring in the stroke volume.
Yeah. So how would you do that? Leave the rate out of it. That's going to make it too complex.
Volume is
How much it can hold, and the stroke volume is how much actually leaves. So you divide the total volume into the amount that leaves, and you get the ejection fraction. That's how it's that simple. A lot of this stuff really is not that hard. But we see these words around it. It's like, oh my God.
And how are they able to detect the actual, like...
That's with an echocardiogram. They'll do that with the ultrasound. And, you know, so they can actually identify how much is moving, and they can measure the flow, and they can measure the size of the ventricle and how much actually goes out. They also can do it radiologically. When I was dealing with patients who were post-cardiac surgery and post-MI, we also sometimes would look at, you know, you would actually inject a certain, no, not a dye, but cold saline. And the sensor in there would measure the temperature rise, and that would tell you the rate of mixing, which would tell you what the volume is moving in. Because that, when you mix cold water with warm water, you can figure out the differential and how much water it takes. And basically, so yes, it's blood, but we're doing that kind of an equation that says, because if you want to see how, well, because the dye is, you know, most of us don't want a whole lot of radioactive dye, and I can do that with my patient every hour and see how their heart is doing, you know, and it would be something actually we would do like every 4 hours or whatever as part of our assessment for a patient who is like post cardiac surgery, you know, open heart, to see how their heart is actually doing and figure out their cardiac index. That was how you'd figure out the cardiac index, which would say how, you know, what drugs you needed to adjust to keep their heart in the range that the doctor had ordered. It's kind of cool. It's, you know, you're watching the monitor and you pushing stuff and measuring, and then you figure out the cardiac index. It's really kind of a cool thing to do. What is preload? Okay, so preload is you've preloaded the heart with blood, so it's fully stretched. That's before it contracts. And afterload. What do you think? Well, you figured out the preload. Go for the afterload. You're on a roll here. So, do you think preload and afterload are related to ejection fraction? Yeah. Okay, they're all hooked together. Let's talk about modifiable versus non-modifiable risk factors, or risk factors in general. Can I modify my age? I'd like to. Can I modify my weight? I'm working on it. Yeah. So I can't control who my parents were. I do take atorvastatin. Gender is getting to be a little more blended, but with, you know, for the moment we'll say we don't modify our gender. Can I control my stress levels? Yeah, I could choose not to come to class and just sleep in. It'd be great. Yeah. I don't smoke, and my blood pressure is controlled. But I have a hereditary issue with blood pressure, and I've been on blood pressure medication since my 20s. It happens. And controlling my weight would be a good choice. So what's the problem with LDL versus HDL with, you know, cholesterol? What's the deal there? Why is LDL bad? You know, knowing the why can be useful. It's more likely, it's more involved in the formation of plaques. And actually HDL reduces the formation of plaques. That's why you want those proportionally, one high and one low. Yeah, statins. Big bucks with the statins. Zocor, simvastatin. What's the biggest risk with statins? What do you need to educate your patients about with statins? Somebody volunteer. Can I point? Shall I just point? Yeah, tell me what's the primary thing to educate your patients about with statins?
I have no idea.
Oh my God!
Or else I wouldn't raise my hand. I can find out for you. Wasn't it like you can't eat?
What is it actually? Yeah, there are some dietary restrictions, but more importantly, there's a condition you need to educate them about, that they need to report should it occur. Muscle pain. Okay, so muscle pain is the symptom. What's another symptom associated with that they should be aware of? Back pain, which would be associated with what organs? Kidneys. And why would their kidneys be involved? Well, it's not a toxicity, it's about a response. So have you ever heard of rhabdomyolysis? Oh, yes, which is muscle breakdown. So some people will exhibit this severe muscle breakdown. And of course, the symptoms are muscle pain, back pain, dark urine, because they're dumping all the myoglobin, myoglobin into the urine. And the kidneys don't like those huge molecules. It's really, damaging. Okay. So let's talk. What's the difference between statins, fibrates, and resins? You all did your reading, right? Because I didn't have you take a quiz where you'd have to actually answer these questions. Or did you all take a long break? I see a smile here and there. Okay. So statins do what? They actually impact the liver's production of cholesterol. Okay. What do you think? What do you think about fibrates? Pharm's going to be a really tough class next semester. Okay, fibrates increase the excretion of cholesterol into the bile. And then it goes to where? Where does bile go after you put stuff in the bile? Where does the bile end up? Colon? Good. Okay. And what about Well, it moves the cholesterol gets dumped into the bile. That's what fibrates, promote that. Okay. And then, of course, we have resins, or they're also sometimes known as sequestrants. What is it to sequester something? Encapsulate it, to hide it away. Okay, so sequestrants, resins, these things actually just grab onto it and hold on to the onto the cholesterol. So they'll be called bile acid sequestrants. So cholestyramine, they literally bind to the cholesterol, and again, they get excreted. Let's talk about angina. Yeah.
Question about resins.
Sure.
So by binding the cholesterol and releasing it, it affects the cholesterol level.
Yeah, so it binds to the cholesterol in the blood.
So will it give you like a cocktail of different statins?
The statins have been so effective that's pretty much what, unless people don't end up on other things unless they are having problems like rhabdo or other side effects. Typically, you're just on statins. At least that's been my experience. The resins and stuff are people who are not responsive to other treatment. But those are also the older treatments that were first invented or discovered. Was, let's see if we can pull it out of the blood and dump it one way or another. So we talked a little bit about angina earlier. Let's talk about it more. It says up there, what is it? So ischemia, okay. And so if you have a patient who is complaining of anginal pain, what is the first thing they need to do? Very first thing. Sit down, lie down, yeah. Because it can be, we have our patient with their 90% occluded LAD and they're having chest pain because they're walking up the stairs. What's the solution? Rest. Okay. Now, there may be other solutions that are, interventions we need to do later. But the goal is to increase the demand. And what's the other thing, if they happen to be in your ED, that you're going to do to help them out? Oxygen, because the heart is, did you have a question? Well, you want to decrease the demand and you want to increase the oxygen. So what drugs are effective at improving the coronary circulation to the heart? Nitroglycerin. So what does it do? It vasodilates. So it makes everything bigger and it lowers your blood pressure. So not only does it vasodilate, but it also reduces the cardiac workload. It doesn't have to work as hard to pump blood out because your blood pressure has dropped. Now, they may pass out too, but I guess that's better than being dead or whatever. Well, okay, so there's two kinds of angina. Well, there's three, but we're only going to talk about two of them today. So Mr. Jones here comes to the ED and he's been developing severe chest pain. He was mowing his lawn. So what's SL? What's that SL nitro? Sublingual, yeah. And even though it doesn't have a subscript, what's O2? Oxygen, right. So you give them nitro. Now, what is the standard dosing for nitroglycerin? Nobody knows? And what interval?
5 minutes.
Yeah, one dose every 5 minutes. And what happens if it doesn't relieve the pain? I can't hear you. Call the ambulance? Yeah. Well, it probably, it may well indicate that they don't have angina. Or it's unstable angina or some other reason because it's not effective. So they need to be further evaluated. So if giving them nitroglycerin and oxygen relieves their pain, then they probably have what's known as stable angina. What is unstable angina? Yeah, you're watching TV and all of a sudden it hurts. So let's go back to our guy with the 90% occluded LAD. And maybe he's got a little piece of something floating around in there, and every once in a while it occludes the artery. He'll perhaps show symptoms of unstable angina if he's lucky, because it'll occlude and then unocclude. But so anytime it blocks the flow more, he starts having symptoms. Doesn't matter whether he's moving or not. What's the risk with unstable angina? Hey, you're going to have a full-blown MI. It may just occlude and stop, which would not be a good day. So can be known as a pre-infarction because they're at the. What's the difference between ischemia and infarct? Ischemia is a shortage of oxygen and nutrients. What's infarct? Dead cells. Right. Cell damage. And the thing with unstable angina is it is unpredictable. So usually if a patient comes in with unstable angina, they're going to get admitted and they're going to get worked up for whether they need stents or a bypass or whatever. Maybe they can medically manage it. It depends. Let me get a few more slides in and we'll take a quick break. It's about that time, isn't it? You're all already exhausted, I can tell. So the thing about chest pain, these are the classic symptoms. What's different for women? This is more or less classic for men. Fatigue, back. They have. Why is it that we know so much more about men than women? Men with all the tests. Men were what? Say it. I like that.
Manny, that's horrible.
Well, it's true.
Say it out loud again.
Sorry. Because classically we're a male-driven society. Right?
Well, classically, they were the ones that got tested. And women that had these other weird symptoms were, oh, well, she's just tired. She was actually having an MI, but they didn't detect it. So actually the rate of death for women from MIs was much higher than it was for men because they weren't detecting it. So these are the classic MI symptoms. But a lot of times women, particularly middle-aged women, will complain of malaise, fatigue, back pain. They won't necessarily have the crushing chest pain and left arm. That's you need to broaden your view of what chest pain is, particularly with female patients. So the first lines of defense or treatment: lie down. I like this, and be calm. Now, of course, you're terrified because you think you're having a heart attack, but calm down. Yeah, well, even if you are, calming down will help your symptoms. Oxygen and nitrates. And as we mentioned, there's more than one way to give nitroglycerin. And particularly, we're thinking for home administration right now rather than in the hospital because there's more than that. But the two that are common for a patient that's, say, outpatient, what are the two different ways they might be able to do their nitro? What did I hear? Well, aspirin's not nitroglycerin. No, that's going to be in the hospital. Sublingual. They actually have an inhaler. Yeah. What's the thing about it? Why is it given sublingually? It's faster. That's a really well circulated area. There's a lot of blood vessels there, and it dissolves and it's picked up quickly. What about inhaling something? Is that even faster? Yeah, because it gets lungs to the heart. Boom. No, yes, you're right. In the hospital, they'll have a nitro patch, or maybe even be on a nitro drip, or well, hopefully not both, because then their blood pressure is going to be dropping to the floor. But there's nothing like trying to manage a patient's blood pressure, and they're on a nitro drip, and you're trying to titrate it, and you can't figure it out, and on your assessment, you find out that somebody left a patch on. It's like, thank you very much. Meanwhile, their pressure is like, 50/20. You've got the head reverse Trendelenburg, and you're giving bolus. It's like, oops, somebody left the patch on. This is probably a good time to take a 10-minute break. How's that? Please. So let's talk about the development of a heart attack. So first you have this formation of these atheromas, which are, what we call plaques, which is basically a clump of fat inside the artery, and it's covered with a smooth layer, and that causes endothelial inflammation. And the high LDL levels play a role in the deposition of these atheromas. So we all get some degree of buildup in our plaque in our arteries. And if it becomes further inflamed, the risk is, we actually have microclots forming and breaking down all the time. Clots don't just happen at the point of injury. You actually have clots forming and breaking down all the time. When you have these atheromas, if they become inflamed or ragged, the risk is that they will catch these mini clots that are floating by. And the more clots you catch, the bigger the clot gets, and then you get into problems with an occlusion. So inflammation plays a role in all of this. There's more and more research saying that inflammation is the underlying cause of almost everything. Almost all of our disease processes have an inflammatory basis, which is kind of interesting. So you know, your arteries can dilate as much as 6 times over their normal size, which is how you normally compensate for, you know, with exercise. That's how we manage to get more blood flow to the muscles when they need it. So what will also happen is the blood, you know, the artery will dilate in response to these clots in an attempt to keep the blood flow. But the problem is you reach a limit, and then of course if you keep developing that clot further, you get occlusions. So let's see where we go from here. So what's the difference between somebody who's having a heart attack versus somebody, or an MI? Let's call it an MI. What's MI stand for? Infarct, right, myocardial infarction. So how do they look different from somebody who's having angina or ischemia? Yeah.
Angina is it's brief, there's lack of oxygen or blood going to the thing, and then myocardial infarction is necrosis of the tissue.
So how are they going to be different in your, you know, when they come into the ED, how are they going to respond differently to your treatment?
Oh, you mean the symptoms?
Yeah, how do the symptoms, they come in, I have chest pain. I'm your patient. I have chest pain. What are you going to do for me? What are you going to do for me, the patient with chest pain?
Angina has nothing to do with MI.
Well, tell me what treatments I'm likely to get. What medications? Short term, right in the moment. What are you going to do? Okay, so we haven't talked about Mona yet, and Mona doesn't happen in that order, but you're on the right track there. So tell me, what's the first thing you're going to do for me? Okay. Is an EKG going to do anything for my symptoms? Actually, it'll be nitroglycerin first, unless their O2 sats below 94%. So if I'm having an MI, will I respond to the nitroglycerin? If I'm having an MI, will I respond to the oxygen? Maybe somewhat. Well, you're going to sit them down. You're going to give them, assume you're going to have orders for stuff like this, but you're going to start with the nitroglycerin. Oxygen if they're under 95%, 94%. Aspirin, is it chewable or do they just swallow it? Chewable. Why? It's faster, absorbed faster, right? And then oxygen and morphine. Why would you give them morphine? What does morphine do for them? Well, it does relax them, but it does both. It actually increases cardiac blood flow, and it reduces their pain. And what happens to their anxiety level when you reduce their pain? So does anxiety do anything to your heart rate? So that's the reason, in part, for the morphine. Will an MI patient have their symptoms resolved with those 4 treatments? Probably not. Whereas your angina patient will probably respond and say, "Oh, I feel much better now. Can I go home? I don't want to spend all day here." So the difference is that with ischemia, which, as you said, is temporary in nature, that they are going to respond to those measures that improve blood flow, improve oxygen, improve their, reduce their anxiety. All those things will lead to an outcome that is they're feeling better. If they actually have an occlusion that is causing, not only ischemia, but perhaps even, an infarct, it will perhaps mitigate the symptoms, but not resolve them completely. Good. So what changes in the EKG? So if there's actually been an old MI, you'll hear about an abnormal Q wave, an inverted Q wave. You see that sometimes. So this ST elevation, so what's the ST segment? Where is that in the heart? Where is that in the EKG? What was on the quiz here? How is the ST segment different from like the T wave? What does ST stand for? Where did that come from? Why is it called the ST segment? You probably didn't read that. But so you've got the QRST, right? So at the end of the S wave and the beginning of the Q wave, there's a segment in between. That's how it got its name. It's just the segment. And should that segment be at the same level of the same electrical level as the incoming before the heartbeat? We haven't talked about this yet, but the answer is yes. It should be at the isoelectric level. So basically, normally you have this segment before the P wave, and the ST segment following. They should be at the same elevation when you're looking at that EKG. And if it's above or below, that indicates problems. Have you heard them talk about somebody having a STEMI? Have you seen that in your histories? How about an N-STEMI? You haven't seen N-STEMI yet? Have you not been in a cardiac unit yet? Oh, okay. So what's STEMI stand for? ST elevated myocardial. So what happens is you get the ST wave is elevated. It's above this isoelectric line. What's an N-STEMI? I couldn't hear you.
I said lower.
Well, it's non-ST elevated. So it means that they had an MI and there's either elevation or sometimes there'll be ST depression, which will be referred to as an N-STEMI. And they both talk about whether it's elevated or depressed is talking about the level of injury to the heart. In both cases, there is permanent injury. And then when there's ischemia, you get these other waves, this inversion. So when you're in when you're working in the ICU or you're working in the ED and you're seeing these people come in, you'll learn to read these EKGs at least to that level of if their ST segment is elevated or changing in elevation or dropping, and that patient's under your care, you're calling the doctor because there's problems. We're still having problems with that patient, and you're going to start seeing dysrhythmias probably associated with that.
What really happens in the heart when there's a STEMI? Is it still pumping when it's not?
Well, if it stops pumping, they're dead. So, yes, while there is electrical activity and the heart is able, the elevation just tells you that there's ongoing damage. However, if the damage is too severe, the heart stops and they die. Okay, now we're talking about fibrillation. So you won't have this with fibrillation. What you'll have is, instead of that, you will have something that looks like this, because it's no longer a coordinated electrical impulse. With this, it's going, it starts out at the SA node, or the atrial node, goes through the SA, down the Purkinje fibers and out, and it's very coordinated and all, and that's what creates all of that nice wave. With fibrillation, everything's firing on its own. It's all uncoordinated and it's doing, and so it's just quivering and it can't pump. You've all watched on TV, right? Flatline, shock them, right? Does it work? Can you shock a flatline? Well, you could, but it won't do anything. It won't do anything because they have no electrical activity in their heart. That's why there's a flatline. If there's no electrical activity in their heart, there's nothing for that shock to work on. The reason for that shock is to take and stun this to get back to the coordinated thing. It doesn't, basically it's like resetting your computer. It's a reboot. But if there's nothing going on, there's nothing to work with. Yeah.
So then how long would it take for that electrical current in the heart to go away completely? Like how long do you have where you can shock them and still get the
As long as there is electrical activity that's shockable, you'll shock them.
So how fast does that go away?
Seconds. It can just disappear. And they may not, that's why in your ACLS protocols that you're going to be learning about as you get further down in the process, you do things like CPR. Because what you need to do is basically get blood flowing through the heart so that it has the nutrients and everything it needs in order for the potassium and calcium pumps to work. But if there's no fresh potassium, calcium, and glucose and oxygen, nothing's going on. You're dead. You know, my ACLS instructor always talked about when you're working with a dead person, because when you're doing ACLS, they actually are dead. It's only your heroic efforts that hopefully will bring them back. And, you know, if their heart's able to respond and they're lucky, then they do. What percentage of people survive an MI in the hospital? You know, an observed cardiac event. They call a code. What's the survival rate? Not according to TV. What?
No, I said it depends on your hospital because I know.
Well, it depends on the hospital to a degree, but there are general statistics. 20%, 30-day survival rate. 1 in 5 makes it out alive. Most people don't make it. Anyway, I should move on. I've got 15 minutes in which to go through another 30 slides. Oh, God. I better speed up here. 40 slides. You all know what troponins are? Have you seen patients that are getting their troponins drawn, their cardiac enzymes? Anybody worked in the ED yet? Had a patient come in and they draw cardiac enzymes? Yeah. What did you find out?
Latino man came in, he had heart pain the day before, and then heart pain again, and the troponin is
So troponin is actually when the cells die, they release troponins.
Yeah. So he was fine. There was no troponin.
So his chest pain wasn't due to cell death.
No.
Could have been epigastric pain. It might have been heart pain. Maybe it's ischemic. Although usually with ischemia there is some leakage of troponins.
Cardiac testing.
So have any of you seen the frequency that they draw cardiac enzymes?
Is that 3 hours or 3 days?
It's every 6 hours, because they peak very quickly. So if they're increasing, it says there's continuing cell damage. And if they're dropping, it says, well, the worst of it's over, but you know, we have things to do. So who's the one with the vague symptoms? Who's the least likely? They come in and you're going to try and figure out which one of these is the hardest to detect a heart attack.
I have a question.
Yeah.
What's CABG?
Oh, a cabbage? Have you heard that term?
No.
Okay. Coronary artery bypass graft. Open heart surgery. You've heard about bypasses, right?
Yes.
Okay. That's all it is. And it will be commonly referred to as a cabbage, and they'll say things like, he had a 4-vessel cabbage. So what's a 4-vessel cabbage? They bypassed 4 vessels. Yeah, okay. So looking at these people, who's the least likely to be classic symptoms? The diabetic lady? Yeah. Windy. Women and elderly patients and diabetics often don't have those usual signs and symptoms. We've talked about MONA. Now, MONA is a great acronym because you can remember it, but it's not the order of administration. The order of administration is actually nitroglycerin, aspirin, oxygen if they need it. and that it used to be that you always gave oxygen. I would probably, if it were me, probably just on the safe side give oxygen regardless. But typically, if their SATs are above 95%, you don't need to give them oxygen, and then morphine if they're not responding to the others.
So, say that again, nitroglycerin, aspirin, oxygen, morphine?
Yeah. Well, actually, it'd probably be nitroglycerin, oxygen, aspirin, morphine. I'm going to put oxygen on because it's easy to do. I don't have to go to the Pyxis and get it. But, yeah. So why do we give morphine? We talked about it a minute ago. Yeah, reduce anxiety. And that's beneficial. What else does it do? It actually dilates the coronary artery. I mean, it actually does improve oxygenation to the heart. Okay. And what do we look for? When you're giving nitro, what are you going to be looking out for? Well, you probably ask them that before you give the nitro. But what is the concern you have in either case? Hypotension, yeah. They could drop right through the floor. And then we've got the anticoagulants. So, while we're treating this patient, if they're going to go in for a graft or they're going to go for a stent, what's the reason for these anticoagulants? What do they do in general? They reduce the clot formation, right. Do any of these break down clots? No, none of these drugs do. They're not TPA, streptokinase. Okay. Yeah, let's talk about beta blockers. So what do beta blockers do? What site do they act on? Beta 1, right. And why do we know that? What's the mnemonic? How many hearts do you have? One. How many lungs do you have? So, haven't I said that in this class before? However, there is crossover. Now, the intended target is the beta 1 site. What happens if it activates on the beta 2s and they're asthmatic or COPD? Yeah, they can go into an asthma attack. Yeah. So that's when you might not give a beta blocker. Although they may, weigh the risks. If they really need the beta blocker, they may try and, ameliorate the other side effects. So how's that beta blocker going to help your patient who's having a heart attack? Okay, so slowing down the heart does what? Workload, there we go, good word. So it reduces the workload. It also does reduce blood pressure. So what else does it reduce? Afterload. So it reduces how much work the heart has to do to even push the blood out. Okay. ACE inhibitors. These are kind of good drugs too. What's the most common side effect that people complain about with ACE inhibitors, particularly lisinopril? Cough. Yeah, they get a dry cough, particularly when they lie down. Makes them insane. They can't sleep. So the ACE inhibitors, what does ACE stand for? What's that acronym mean? And are we activating it or inhibiting it? Okay, good. So it's in that renin, pathway, which renin causes vasoconstriction, and the ACE, angiotensin, is one of the precursors, and we break that down. And one of the other side effects or beneficial effects is it prevents remodeling, both renal and cardiac remodeling. What is remodeling? See, I used a word and then I didn't tell you what it was. What is renal remodeling due to hypertension?
Is it hypertrophy?
Yeah, so your body, the organs respond to the high blood pressure, and they start literally changing their shape in response to all this extra pressure. And you don't want that because it ultimately means that they're being damaged. So to prevent remodeling is to, it's both cardio and renal protective. So if they don't get the cough, it's a very good drug. Plus it also is mildly diuretic. Often it's combined with hydrochlorothiazide, which is a potassium-sparing diuretic. 25. What am I missing here? Where are we? 25. We've talked about that. Good. So what are the most common complications from somebody who has had an MI? They're up there. You can make a guess. They're probably in order. So, yeah, they can have dysrhythmias. In fact, somebody who's had a stent placed often has a dysrhythmia, and they're called reperfusion dysrhythmias. It's not unusual when they have like PVCs. What's a PVC? Anybody know? What does PVC stand for? Here I use these terms and I forget that they may be new. What's PAC? If you don't know what a PVC is, you probably don't know what a PAC is either, right? Well, P stands for pre. So what's a VC? Yeah, a pre-ventricular contraction. So what do you think a PAC is? Atrial contraction. So when your patient complains about my heart's fluttering, I have palpitations, those are PVCs, PACs. And actually a certain number of those are not totally abnormal. A lot of times people have had the occasional PVC or PAC. Now, but if they start happening in frequency and in runs, then it's a big deal. What's heart failure? In general, you can have right-sided, left-sided, or both sides. But what are we saying when we're saying somebody's in heart failure? It's not effectively pumping. So are they going to have a good EF? No, somebody in heart failure is going to have an ejection fraction of like 40%, 30%, 20%. Cardiogenic shock. Cardiogenic shock's a big deal. Patients in cardiogenic shock are going to end up in the ICU. They're on stimulants. They're on all kinds of drugs. They've got 3 or 4 or 5 drips running. They may have put on a ventilator. They are very susceptible to things like VFib. The heart is so damaged that it really is just like, give me a break. And those are the patients that will end up like on an intra-aortic balloon pump, which is a device that's actually threaded into the femoral artery. It's a balloon about that long. And the way it works, when your ventricle contracts and shoves blood into the aorta, as soon as it does that, this balloon pops open, which of course, the valve closes, but it shoves the blood out and reduces the cardiac workload. And of course, it also reduces afterload preload because when the heart needs to go to pump again, that balloon is deflated and the aorta is basically free of blood. So it's an interesting device to be managing as a nurse. It's actually connected to its own EKG. It knows when the heart is doing stuff, and it's filled with helium. And it's a helium-filled balloon, and it's something you need to be really careful about because helium in the blood causes severe clotting. So if you have a helium leak in your balloon, it's bad, bad, bad. Yeah. Because it is the lightest of the gases. So, it's very easy to move a whole lot of it very quickly. And it does. It inflates in milliseconds. Boom, boom, boom. So what's going to be the thing you're going to be looking for with this patient who just had an MI and is in your ICU, even though you haven't worked in the ICU yet? Or he came down from the ICU, he's in the step down, he's in the tele unit. What's going to be your primary concern for this patient? Exactly. Good. Dysrhythmia. Perfect. So then we get into the treatments. We're going to talk about thrombolytics briefly. So what do thrombolytics do? Which drugs are those? All right, did I hear TPA? Yes. STP, TPA. STP is not what you put in your car. Well, it is, but you don't put that STP in your body. So yeah, the thrombolytics work by actually reducing the clot size. And what's the risk with those kinds of drugs? Bleeding, right. So is everybody a candidate for that drug? Nah. So then those that can't get a thrombolytic, they will often end up going in for a PCTI, which stands for percutaneous coronary intervention, PCTI. Well, PCI. We'll stop with PCI. Suddenly I can't remember what T stands for. But a percutaneous intervention, you're going to go in, and that's when they get a stent. Excuse me. They run, they run a catheter up into the heart on the arterial side. So it's going to go in through the femoral artery so that you can get into one of those arteries, and you run this little thing in, and then, you know what a stent looks like, any of you? Anybody seen what they look like? Have you ever seen the Chinese finger puzzles? Finger. That's actually kind of what they look like. And they have a little balloon inside, and they inflate that under really high pressure. And since it's made out of metal, it expands, and it holds the vessel open. And there's different kinds of stents. There's drug-eluting stents, which means they actually have like Plavix embedded in them to help prevent clotting. It's not all that unusual for somebody to have a clot form in the new stent, so it can be a problem. And these people will be on anticoagulants probably for the rest of their lives. Yeah.
Is there a risk of rejection?
No, because these are surgical. This is not something that's organic. So these are surgical stainless steel or whatever. There's nothing in there to reject. Yeah, good question though. Interesting. Or they can have a cabbage. Now, what did we say a cabbage was? Perfect. See, you got that down. Okay. So would you give this person a thrombolytic? Why not? Yeah, so there's a real high risk that they will die from the subdural that you create after you give them the STP before they have a chance to die from the heart attack. And this is a stent. You can see basically they just go in to put, and there's different kinds of stenting procedures. Sometimes they go in and they just do a balloon and they actually just sort of crush it down and they don't actually place a stent. Other times you get the stent, which is this sort of mesh thing down here. I'm running against the clock here. And a coronary artery bypass graft. So they'll either use like the internal mammary, which is an artery that runs to the chest wall, or the saphenous vein, which is the one that runs down your leg. And it depends. They may use both, depending on how many vessels they have to graft. What's the one thing they need to be careful about with the vein that's different than an artery when they're grafting it in? How do veins differ from arteries? Well, other than the kind of blood they carry? They have valves. Very good. So if you put it in the wrong way, will the blood flow? No. So they have to remember to put they have to put it in backwards, basically, so that the blood will flow to the heart. So and then you're gonna either before or after or both, you're going to have these diagnostic tests. You're going to put them on a treadmill. They're going to take an EKG. They're looking again for ST segment changes. They will attempt to take them up to their maximum theoretical heart rate to see, sometimes people are fine at rest, but again, if they have that 90% occluded LAD, they get up to 10% of their heart rate and they're starting to see ST changes. A thallium scan is a more precise diagnostic. So this is actually it's again a sort of a harmless radioactive scan. I know we're running up against time for you'll get your presentation in. You told me 10 minutes, right?
We're out at 40.
We're at 40.
We can do
Oh, I hate this. Where are we here? Halfway through the slides. Well, we're going to have to figure this out. I did post this entire lecture. It's up there if you want to sit back and listen. You can do both the audio, most of this, we have... Oh, I only had 2 more slides. Yay! For some reason, I thought there were 60 slides. I don't know why. So, all about sex? Well, you all know all about sex. You're nursing students. George Carlin had a line about wanting to date nurses because they knew where everything was. Anyway. So, yeah, after cardiac rehab, you're going to go through these stages. They're going to recover slowly, and they're going to basically diagnose how they're doing. So I better shut up and let the presentation happen. I apologize. I will one of these days figure out when this class actually ends. You guys still need to be proactive and say, wake up, Bob, it's time.